So I have the very monumental task of covering all of these items that you see on your psychiatric outline in an hour and a half. I'm going to do my best. I'm also going to try to pace myself, so I am not going too quickly, but I want to highlight, and you'll see I've color-coded many areas where I want to draw your attention to for high-yield facts for the board exam. I will tell you on the outline, the mood disorder section, I'm basing a lot of our discussion today on two book chapters that I've written that were published in the last 2 years. One on depression that was published in the Lang publication, Behavioral Medicine, and you'll see the reference in your reference section. And I wrote the bipolar disorder chapter in primary care psychiatry. So for those of you who are primary care providers, that's a really good practical book, and we try to make it very practical for people to understand. But we'll be covering all of these topics going forward. I will draw attention to several pearls that will involve, the age of onset, duration of symptoms, decline in functionality, pattern of recurrence, and causative agents as they come up. And I will have special slides on that. So without further ado, we'll jump right into the mood disorders. So major depressive disorder is our big one. It is defined as at least 2 weeks of depressed mood, feeling down, depressed, or hopeless, and or anhedonia, which we typically describe as a loss of interest or pleasure in activities that you used to do that brought you pleasure, and that's what we call anhedonia. So one of those, and for those of you familiar with the PHQ-2, the Patient Health Questionnaire 2, those are the two questions that we ask. Are you depressed, and have you lost interest or pleasure in doing things? And if the answer is yes, we typically go on further with asking the 9 cardinal symptoms of depression, which is captured here in the SIGI caps, where sleep disturbance. Sleep can be insomnia or hypersomnia. Hypersomnia we typically associated with atypical depression features, and insomnia often or early morning awakening is melancholic depression. Interests are diminished, which are captured somewhat in the anhedonia question. Feeling guilty, loss of energy or fatigue, concentration, which is diminished, appetite changes, psychomotor slowing or agitation, and suicidal thoughts. So if 5 of these 9 symptoms are met, that is typically major depressive disorder. Now, when the DSM-5 was just coming out, the big question was, what do we do about bereavement? So there was a lot of criticism when the diagnosis was introduced and defined in the DSM-5 because they excluded bereavement as a kind of normal function. And there are two sides of that coin. If you imagine, somebody has lost a loved one, there is normal grieving that goes along with that. But if it exceeds that normal grieving piece and is affecting life in so many other ways and functionality, that's where early treatment of depression can be considered. Couple of pearls. The mean age of onset often surprises people. With depression, we are seeing it in kids, and it certainly can come early on in age, but the mean age of onset is typically in your 30s. It's typically a bimodal distribution where we see bumps in the 30s and again at retirement age around 60. So those are when we typically see these bumps in major depressive disorder. Again, I mentioned the 2 weeks. That's always a stressed in tests and things of that nature. The functionality can be variable. Sadly, for women in the audience, it is more common in women. 2/3 of cases thereabouts of major depressive disorder are often in women. Very high rates in transgendered individuals as well. And you can see a pattern of recurrence where there's an average of 5 to 9 episodes over a lifetime, which is why we dub major depressive disorder a relapsing, remitting illness. The lifetime prevalence is about 20%, and now for those of us in the pandemic, we've seen rates of depression actually triple. So the annual prevalence is about 7-8%, but those rates have tripled during the pandemic. There is a 50% relapse after the first episode, 80% relapse after the 3rd episode. So if you imagine, the more episodes of relapse you have, the greater chance of yet another relapse happens, but which is why at the bottom, again, I want you to consider major depressive disorder as a relapsing remitting illness. 50% of individuals may not respond to the individual or the initial treatment as well. So on the assessment side of things, it's very important for us to get a good history when we face somebody with depression. And I often encourage my residents and my medical students to actually don't feel pressed. These are primary care medical residents who I tell them, take a session to just focus on the mood issue. Don't try to put together the depression as well as pulling in elements of their sugar control and their blood pressure. You can just bring people back and just talk about the depressive aspects, because there's so many angles that you really do want to cover when it comes to depression, including what I've highlighted here, the suicidal and homicidal ideation piece, which is very important to get a little bit of a history of how many thoughts have kind of gone that direction to life is not worth living, or I'd rather be dead. And that's a very important piece to